Yeah, so hi, I'm Zoe, and following on from attending the previous two conferences here, I was really inspired and wanted to develop a CVRM pathway for our patients because I just thought it was an absolute no-brainer. And looking at it particularly from the cardiovascular point of view, doing it through sustainable QI seemed to completely join up. So I had a gentleman who had a 71-year-old type 2 diabetic, was admitted to hospital with chest pains, went on to have a cabbage, and then was diagnosed with heart failure. And he was discharged home and referred to us in the community. I saw him in clinic for his initial assessment. He was euvolemic, he had good air entry to all lung fields, heart rate was optimised on his dose of bisoprolol at 56 beats per minute, which is back to front on there. His blood pressure was good. He was only on 4 milligrams of candesartan, so that was leaving room to change for better prognostics. He was on empagliflozin, which was started for his diabetes. He hadn't had any bloods done since he'd been discharged. So the first thing I did was then send him off to go and get bloods done, because I couldn't do any titration without that knowledge. 2 days later, I saw his blood results. His HbA1c was 86. A serum K of 5.7. He was already known to the diabetic service, so I asked him his appointment wasn't for 9 months, so I asked him to see if he could bring that forward, get his diabetes sorted so that I could start heart failure therapies. In the interim, gave him dietary advice on low potassium. To cut a long story short, there was a 12-week wait for diabetes. They saw him, didn't increase the diabetes, went for injection techniques, etc. It took about 9 months before he was in a place where I could start introducing prognostic therapies with him. So he was sort of a catalyst for this as well. So I sent out a patient survey, and what I was getting back from patients were, I'm going for multiple blood tests, I've got multiple appointments on every day, I've got no life left. I feel as though it's all about my illness. I also did a staff focus group, and everybody was complaining that patients were staying on our caseload for too long because they couldn't titrate them because of their comorbidities, and we didn't have enough appointments as it was. So that was the catalyst. Had a stakeholder meeting. We process mapped out the service and identified that, if nothing more, by working together, we could at least reduce one appointment. Because if they were coming to us already with their bloods done, we could get on and titrate on that very first, whereas at the moment they were having an initial assessment, being sent home to do bloods, and then coming back before we could start anything. So invited the diabetes. I should say we're a community trust. We work with 3 acute trusts. Diabetes is within another community trust, and they're an integrated service with one of the acute trusts. So as I was doing QI, the idea is you do a small change first, so I decided to work with that one acute trust, invited the diabetes consultant along, the diabetes specialist nurse from the community trust, my QI sponsor, GP and medical director, and the renal consultant, and you'll find out why she's the fairy godmother. I nearly put the diabetes consultant as Maleficent, but I didn't think that was very PC. So this is our driver diagram, working from the QI principles of reducing healthcare activity and reducing CO2 emissions. It had a lot more on there, but I've simplified it down for today. And basically, we're looking at doing a joint admission screening. So if diabetes saw anybody, they would add an NT-proBNP automatically to their bloods so that they would find any potential heart failure patients. We would only need to add a UACR to ours. We did everything else. It was decided that renal wouldn't do anything because there was no point adding the NT-proBNP because with the CKD, that was going to be off the scale anyway. And to develop a CVRM pathway. However, it was at that point that the diabetes said, we love this idea, but if you want us to come to your MDT, you've got to pay us. We have no budget, we couldn't pay them. Renal said, that's fine, I'll come. She's my fairy godmother. She turns up every week, we don't pay her. But for her, she's also gaining because our SOP is that we refer any patient with an eGFR under 30 automatically. So by attending our MDT, we're not doing those referrals. She's saving appointments, as well as the saved blood tests, etc. So this also, obviously, everybody else has talked about the NICE guidance. It all fits in with that. Plus the long-term, NHS long-term plan. 1.2 is all about prevention. 1.4 is about specialities working outside their traditional roles and doing joined-up care. So our smart aim, we decided, was to reduce the number of on-referrals to the renal team for optimisation of prognostic therapies for patients with heart failure and concomitant CKD by 90%. The reason we had it as 90% was because we recognised there were going to be some patients that still needed to be seen by the renal team. Our stretch aim is still to do the cardiorenal pathway, but that's by next year. So our outcome measures were the number of blood tests and appointments that we saved by discussing these patients at the MDT. And we assumed that by discussing the patients, that was one referral saved and one blood test saved. In reality, for several patients, it was multiple blood tests and appointments. Our balancing measure was carrying out the UACR, because obviously there would be some patients, those patients that would normally have been seen by the renal consultant would have had that UACR done. And at this point, that wasn't part of our normal testing. So this is the data. My baseline was 0 because we weren't saving any referrals to start with. Initially, we had an issue that we weren't managing to discuss all the patients we needed to at the MDT. So our second PDSA was to highlight those patients that need to be seen first, because the renal consultant only had an hour and she had to go because she had a clinic. So we would try and highlight those patients at the beginning of the MDT, but we still weren't managing to discuss all of the ones we needed to. So our second PDSA was to form a list of all those patients that needed to be discussed, highlighting which consultant we wanted to discuss with, because we also have a palliative consultant that comes to our MDT as well as the cardio. And that was then emailed out the night before to everybody, and all patients we've managed to discuss since then. And we have actually got, my green line is there actually at 100%, because although 4 of those patients turned out to be complex, all 4 were given the option of being seen in the renal clinic or being managed by us at home with a phone call from the renal consultant. And all 4 opted for that latter. And I collected qualitative data post that, and a couple of the quotes that I got from there. One lady was young with a baby, and she said it may be managed at home by us with a telephone call video, enabled her to spend more time with her baby. And this is a lady that probably hasn't got much longer to live. A 91-year-old gentleman informed me that his time was precious. He didn't want to spend it in a hospital. And another gentleman who could only walk a short distance, can't drive, has no family, needs to be in a wheelchair once he gets to the hospital to get around. His wife walks with a Zimmer frame, so that meant hospital transport, which meant he would have to be there all day. It meant his wife couldn't go with him. He couldn't always remember what was being said. So this way, being at home, his wife could be there. He didn't have to spend the whole day. So our balancing measure hasn't been as good. So everybody was in agreement, yeah, we'll do UACR. Absolutely, yeah, we get it. We know why we need to do it. But that just hasn't happened. So we did teaching. I did teaching with the team. A little bit of improvement, not huge. Focus group, one of the problems they said they had was they couldn't get hold of the urine bottles for the testing. And they thought they had to stay in the patient's home until they'd done the sample and take it away. So we said, no, you can leave the sample with the patient and they can do it in their own time. And we ordered him urine bottles. Problem solved? Unfortunately not. The next thing I did was I audited it and sent everybody a list of patients that they needed to do those UACRs on. That had a little bit of an upturn, but since then we've gone right back down again. I've tried teaching from outside. That hasn't helped. So following on from Helen's talk today, and I spoke to her earlier, I'm just going, because we were only doing it for those with a UACR, and with a eGFR under 60. So I'm just going to add it to the admission. All patients will get it done on admission, because hopefully that way they can't forget it. It will just become routine. And we can audit that in another month, see if that's worked. If that doesn't work, one of the reasons the diabetes didn't want to do this was because they say the GPs are paid to do it, so why should we? So that would be our other option, would be to write to the GPs and say, you've got to do this when we discharge them. So please don't quote any of these figures, because I've just roughly pulled them together for this talk. I haven't actually analysed it all properly, but 75 in the 6 months, at least 75 less blood tests, 75 less outpatient appointments. I've got increased quality of life. I haven't actually got all the data from the Minnesota yet, but if we're going on the fact that we improve quality of life by early prognostic titration, we reduce hospital admissions, then there must be some there. Just on the travel to appointments and to blood tests alone, we've saved 4,138 kilograms of carbon dioxide, which is the equivalent to 2 return flights to Sydney. That's without even looking at the processing of the bloods and things like that. That was too complicated. I need my green team to help me with that data. It's improved equity of access, because a lot of our patients are housebound and can't get out. As well as the fact it means they've got, on the social point of view, they've got more time to themselves. And we've saved £4,087 in consultant time. So next steps, as I mentioned, sorting out the UACR. And with this data, the hope is that I put together a business case to pay the diabetes consultant for a trial period. So yeah, any questions or any suggestions for me to help me on my way?